So when we give this anti-PD-L1, we give the CAR T cell therapies, we give antibodies, it basically changes or affects the stimulatory immunity. But very importantly, unless you take care of the suppressive immunity, this stimulatory immunity will not work. And that is why if you see even CAR T cell therapies, immunotherapies work only in a subset of patients, and there are still 50, 60, 70% of the patients where it doesn't work. And that is because maybe in their microenvironment there is this increase in the suppressive immunity. That means what is suppressive immunity? They are your T regulatory cells, the macrophages, the myeloid derived stem cells. So all these are what we call the suppressive immunity, and unless the body's or the microenvironment is ridden of this suppressive immunity, the stimulatory immunity will not work. And why I'm talking about this is that metronomic therapy actually attacks when I say it modulates the body's immunity, it modulates this suppressive immunity. As you know, the endoxon, low dose endoxon, etc. that we give, actually it affects the regulatory cells. It changes the affects the T macrophages. It affects the myeloid derived stem cells. So all this can change the immunity in the microenvironment. And then what will happen is that basically when you change that, when you basically it affects the hypoxia, the anti-angiogenic therapy is given, there will be less hypoxia in the tumor tissue. When you give the oral metronomic therapy, it may affect your suppressive immunity. So all this will change the microenvironment, and from a immunosuppressive microenvironment, it will change to immunostimulatory microenvironment. And this is very important not only for the immune therapies to work, but also for the radiation therapy to work, also for the chemotherapy to work. So it is a very important concept that you have to change the immunity, the microenvironment, if you have to turn the foe into friend. So these are some good there are many such good review articles. If you get time, you all should read those. And this is what it is. Basically, this I'm showing you a Lamborghini. As you all know, Lamborghini costs in millions. And, the same way, this is your CAR T cell therapy or your immunotherapies when you use the PDL1 inhibitors, all this cost in lakhs. But if you have this type of road, this is muddy road, this Lamborghini is stuck in this road, and even such an expensive car will not be able to drive this in such environment. On the other hand, on such environment, basically in this type of environment, this donkey, which you can see, he's put a BMW label there. So on such a road, such a terrain, this donkey will work better than that Lamborghini. And that is why I say that sometimes simple metronomic therapies may work better than the expensive therapies, especially if you have such microenvironment which is not conducive to your regular therapies. And that is why the new concept that is coming out now is that if you can combine the immunotherapies with metronomic therapies, change the microenvironment, like I told you, decrease the inhibitory immunity, decrease the angiogenesis, convert it into more, decrease the hypoxia in the environment, change it to a positive environment, then your immunotherapy may work better. And therefore, there is new concept of adding immunotherapy to the metronomic therapies and improving the outcomes. There are many such reviews, you can go and read that, but at the same time, we have done that in the clinic also. You all must have seen last year we presented in ESCO, Vijay Patil from our group did this study wherein we gave low dose immunotherapy along with oral triple metronomic therapy, and improved the outcomes in head and neck cancers. We are doing the same thing in other type of cancers also, but I will be talking about individual therapies in the next talk, so I have not included it here. But very importantly, if you combine the immunotherapies with the metronomic therapies, maybe we'll be able to improve the outcomes better, because what will happen is that now this expensive car will be running on a smooth road, and then it will run better. And that is why we hope that in the future, combining metronomic therapies with the basically immunotherapies, it will help us to improve the outcomes of patients. So what I want to say is that there is a lot of advantages of using metronomic therapies. As we all know, these are low cost therapies. Very importantly, at least at Tata Hospital, we are using drugs which are mostly on the WHO essential drug list. We have used along with oral methotrexate, oral endoxan, we have used oral etoposide. Along with that, we use basically, many drug repurposing that we do. For example, we are using, celecoxib in head and neck cancer. We use tamoxifen as anti-angiogenic therapies in sarcomas. This is high dose tamoxifen, not the 20 milligram dose, but we use 40 milligram per meter square dose, which is anti-angiogenic dose of tamoxifen. Then we use basically, metformin, for example, which is a mTOR inhibitor. We use propranolol, which is an anti-angiogenic agent. So we have repurposed many of the simple drugs and have combined them with basically oral low dose chemotherapy and improved the outcome. So I will be showing all the different areas that we have worked with in the next talk. But this all like these drugs are used orally. Many of this is home-based treatment. So especially it is important for patients in rural India where they cannot come every time to the OPDs, or basically these are again low cost therapies. So this cost, compared to the basically bevacizumab, which costs in lakhs per month, propranolol costs not more than 20-30 rupees for a month's treatment. So we have used such simple therapies in many cancers, including triple negative breast cancer, oral cancers, ovarian cancers, and angiosarcoma. So there are multiple areas where we effectively use metronomic therapies. Another thing is that doesn't require or it requires minimal monitoring and supportive care. We hardly have any IV lines. You don't require antibiotics or nutritional support, blood product support. So all this is not required most of the time. No need of complex infrastructure or highly trained human resources, especially in India where, except for cities, if you go to the second, third tier cities or rural India, there is very little support that these are cancer patients get. So this type of therapy is ideal for, basically giving as maintenance therapy to our patients who cannot stay in Mumbai for a long time. And very importantly, like I told, we have shifted from drug discovery to drug repurposing. So we can use this in three settings. Very importantly, as we know, the most area where it is used or it is considered to be most effective is in patients with relapse or recurrent disease. So definitely it is used there. But very importantly, it can be also used curatively in the perioperative period. For example, when you do a surgery, immediately you cannot start them on basically again high dose chemotherapy, etc. And as we know, during the perioperative period, that is the period where the angiogenic switch occurs, because when you removed the primary tumor, which is secreting a lot of anti-angiogenic agents, this is the Judah Folkman's hypothesis, where you know that in osteosarcoma, if you remove the large tumor, within the 2-3 weeks that the patient comes back for follow-up, this was the old days when basically we did not give any chemotherapy. They will come with large metastasis in the lungs, which is to call cannonball appearance. So, if you give some agents during the perioperative period, maybe we can prevent the angiogenic switch and prevent the relapses from occurring. And very, very importantly, now this is occurring and this is becoming standard of care is many of our patients with advanced, like stage 3 cancer, where we know that after giving the so-called standard therapies, there is 30, 40, 60% risk of relapse. In those patients, we can basically give maintenance therapies to these patients. So definitely it is during this period that we'll be able to help our patients. So those, like I told you, though this is used in palliative setting, it may be effective in primary setting also. Role in perioperative period, like I told you, many of these therapies are non-genotoxic. There have been studies already, like for example, etoposide, when we give in injection, it can cause secondary AML. But when we have given low dose etoposide for years also, it has not produced any this thing. And there are studies which have shown that low dose oral etoposide is non-genotoxic. So many of the therapies that we give do not cause genotoxicity. So we give this combination, like I told you, there should be a combination of drugs, one to target the tumor, one to target the microenvironment, and the third maybe to modulate the immunity. So these are different combinations that we use. And very importantly, these are personalized treatments, not the same combination works for all the cancers. For example, in head and neck cancer, there's a lot of inflammation, as you know, in the tissues, in oral cavity, in the oral tumor. So there we use anti-inflammatory agent like celecoxib. In triple negative breast cancer, there's a lot of increase in the mTOR or the insulin-like growth factors. So there we use mTOR inhibition of metformin that has worked well. In angiosarcomas, there's a lot of angiogenesis. So we use anti-angiogenic agent like propranolol. So for different tumors, we use different drugs along with the drug which is most effective for the tumor. So there is a different combination for different types of tumors. So it's not one size fits all, and that is why people, if you see in the West, most of the time they've used etoposide, they've used endoxan, and basically, cyclophosphamide, and they have cyclophosphamide and methotrexate, I mean, and it doesn't work for all tumors. So you have to have a different combination. So what this says is that basically, if you see, if you give only chemotherapy, this is the outcome. If you add standard or other therapy, basically it slightly improves the outcome. If you this targeted therapy, so if you add the checkpoint blockade, it improves the further. But if you combine maybe the, like I told you, the metronomic therapies along with the checkpoint blockade, maybe the outcomes will be much improved, and that is what we are hoping to do in the near future. So combination of chemotherapy along with oral metronomic therapy, along with the checkpoint blockade, along with the CAR T cell therapy, and that may improve the outcome. And this is my last slide. So, many of you must have seen the film Chennai Express, where Shah Rukh Khan uses this dialogue again and again, that don't underestimate the power of common man. So sometimes I say that simple therapies which hardly cost anything, sometimes they also give excellent results. So don't underestimate the power of metronomic therapies. But definitely we have to do a lot of research, lot of studies in this subject. But hopefully the younger generation is interested in you doing studies in this, and in the near future we may see much better combination of drugs, combination of metronomic therapies with the immunotherapies, and some really good outcomes. So thank you very much for your kind hearing, and maybe next time we'll talk about individual diseases where we have used the this metronomic therapies. So thank you, and if you have any questions, I'll be glad to take those. So I can see, can I answer the questions now? Hello?
Yes, sir.
Can I answer the questions?
Sure, sir.
So I can see one question, what are the recent advances in low dose therapies? So you must have seen, there's a lot of research going on at present. For example, there is data Vijay Patil in our group from Tata Hospital, Dr. Kumar Prabhash. You must have seen a lot of work being done in head and neck cancers. In brain tumors, is doing some work. So Dr. Vikas Oswal, Anant Ramaswamy, they are doing in GI cancer. So a lot of work going on, but there's still, this is a new area, comparatively new area, and we need to do much more work. And now, especially that immunotherapies are available, our data has shown that low dose immunotherapy also works very well. This will bring down the cost, and once we have a generics, maybe that will give rise to further stimulus to the this type of research, because at present we really cannot do research with immunotherapy molecules because of the cost, but that will take place in the near future. So a lot of work is going on, but still a lot more needs to be done in this area. So, like Supreet has asked, sir, kindly explain the conversion of immunosuppressed tumor microenvironment to immunoactive one by OMCT. So OMCT basically is of different types. I told you. One of the main areas that we use this thing is the anti-angiogenic as anti-angiogenic therapy. So many of the chemotherapies in low dose are also anti-angiogenic, like even cyclophosphamide basically is anti-angiogenic. So in low doses, along with the immunotherapies, then we have low dose, etoposide is anti-angiogenic. So there are many drugs which are anti-angiogenic. And what happens when you give this type of therapy? When it decreases the angiogenesis in that, the hypoxia also decreases, because like I told you, when there is new angiogenesis, these are leaky vessels, so there's a lot of infiltration out in the tissues, and because of that there's raised interstitial pressure that causes hypoxia in the tissue. So when you do this type of therapies, decreases the angiogenesis, improves the oxygenation of the tissue, it basically improves the microenvironment. Along with that, we use, like I told you, cyclophosphamide, for example, is also anti-T regulatory cells. So this is anti-macrophages. So these are the negative immunity is basically the macrophages, the basically the T regulatory T-regs or T regulatory cells, the myeloid derived stem cells. So all these are in the tissue, which are basically the the immunity which suppresses the immunity of the or the cells which suppress the immunity. And basically what we do is, when this metronomic therapy kills those cells, then basically it changes the environment from immunosuppressed immunity or to immunoactive or stimulatory immunity, and doesn't have to be totally gone. So for example, there's always a balance between the stimulatory immunity and the suppressive immunity. So if you change the balance from suppress it, just bring it down, the stimulatory immunity will get an upper hand, and then basically the drugs will also work better. The immunotherapy that we give will also work better, and that is the concept of basically changing. And there are good review articles on this. So if you put that tumor microenvironment, metronomic therapies, you'll get a lot of articles on that. You all should read those articles also, because it will give you a better picture of how this is done. And randomized trial, like I told you, there's one randomized trial. There are some randomized trial we have done. The other randomized trial which was done was by doctor, for example, Dr. Basically, Lalit Kumar from AIMS, where he had given Pezopenib versus